Nobody recommends it.
Well, thank you all for coming to the Diagnostic Conference today. We have a very special guest speaker all the way from Witham Hospital in Lebanon. It is Dr. Christopher Huffer. He is a pulmonologist and has been there at Witham for 4 years. So I'm going to go ahead and let Dr. Huffer take over.
Sure. Thanks for the opportunity to come. I have a bit of history with this hospital in Frankfurt. I grew up just across the border in Carroll County. And my grandma was a patient, Dr. Stout, and actually when I was in medical school, I spent a month, 6 weeks following around Dr. Tharp in 2001, and went to a couple conferences in this room back then. So, and I live out in Clarks Hill now, so I'm in Frankfurt all the time. So thanks for letting me come. I put this together basically predominantly on my own biases, supplemented by literature and finding some tables to illustrate things that I believe. So this is mostly, well, exclusively my opinion backed up by some data. But if you have questions or comments you want to make, please go ahead. I'm not sure if this is too basic or not basic enough, but if you have questions about anything, please let me know. This is a new talk for me. I want to start out by talking about asthma, because asthma will actually be, praise God, a more infrequent cause of needing mechanical ventilation or non-invasive positive pressure ventilation. So we'll kind of get asthma out of the way first and then talk a little more about COPD. As we all know, asthma is a real problem in the United States, and it's actually getting a little worse. The asthma prevalence is increasing slowly. We're not sure why. There's a hygiene theory of disease that our children are not exposed to enough antigens in childhood, and maybe that's the reason why they get this hyperimmune airway hyperresponsiveness later in life, or maybe we're getting better at diagnosing it, or maybe there's more pollution, we just don't know. But the overall asthma prevalence in the country is almost 10% now. But fortunately, most of them don't have to come to the emergency department. You can see the rate of ER visits per 10,000 population and the rate per 100 persons with asthma. So your asthma emergency department visits will be about 9% per year. But keep in mind, that's total number of visits. So most of your patients, your problem patients, have more than one ED visit per year. So it's not 10% of all patients, it's just 10% per 100 patients. And then the hospitalizations is even less, so about 2% per year of asthmatic patients will be hospitalized. And then the rate of death, thankfully, is pretty low, less than 2 per 10,000 persons with asthma per year. But keep in mind, considering the high prevalence of asthma, that's still about 5,000 deaths per year in this country. Asthma is a disease that still kills people. So the risk factors for death in asthmatic patients, mostly what you would think. So patients that are at risk for death are patients that have tried to die on you before, patients that have had a previous severe asthma attack requiring an ICU stay or intubation, patients that have big swings in their peak expiratory flow. So your asthma patient that's going to be at risk for dying is not your patient that has kind of the burned out asthma that's always short of breath, always fixed obstruction. It's your patient that has these dramatic swings in their peak expiratory flow, where some days I'm fine, I pet a cat, and I'm suddenly short of breath and I can't breathe. Those are your patients that are at risk for crumping. Patients that have asthma exacerbations despite chronic oral prednisone. So your patient that's on prednisone every day and still having flare-ups is higher risk. Patients that are burning through their Ventolin or burning through their ProAir in less than a month or less than 2 weeks, needing refills, are your big risk patients. Lower socioeconomic status, so inner city, patients that are poor, patients that can't afford their medicines, non-adherence to medicine. So your risk factor patient is not your middle-aged churchgoer, it's your young person who's still smoking, who is not taking their medicine, missing office visits, stuff like that. And there is some weak evidence about when you de-escalate steroid therapy. So when you're coming down on prednisone, that patient is at a higher risk for having a flare-up. So when to intubate an asthmatic patient in the emergency department or in your ICU? In my opinion, this is the scariest situation in respiratory medicine. And it's not like I or any pulmonologist has decades of experience doing this. I've intubated one asthmatic in 5 years. deciding on when to intubate an asthmatic depends a lot on serial clinical evaluation. So it's not just your patient that looks terrible, it's like, do they look terrible and are they looking worse 20 minutes later despite 10 milligrams nebulized of albuterol. So other things that can kind of give you a hint, obviously clinical evaluation. So respiratory rate greater than 40, accessory muscles, tripoding, leaning over the gurney like this, inability to talk, and certainly if the asthmatic that is now starting to pass out, become somnolent, lethargic, is terrifying. Most asthmatic patients, when you check their blood gas, they ought to have a low partial pressure of carbon dioxide. So their PCO2 ought to actually be low if they're in the middle of an asthma exacerbation, because they're huffing and puffing, they're breathing hard, they ought to be blowing off PCO2. So PCO2 of normal, of 40, which is technically normal on your arterial blood gas, should make you very nervous about your asthmatic patient. That's not normal considering the way that they're breathing. And your gut, you know, this patient looks like crap, they probably are somebody that may need to be intubated, and you should consider that. That's all I can tell you. Yeah.
Does the serum bicarb, if you haven't gotten the blood gas and you're initiating your evaluation, can you use that as a surrogate of PCO2?
No. And the reason why is that the serum bicarb compensating for your PCO2 is actually excreted by the kidneys and takes days to compensate. So somebody that has an acute hypercapnia, so normally they're fine, but yet right now they're in respiratory failure, their bicarb should still be normal and their PCO2 can be high. Now your chronic hypercapnic, like your COPD patient that lives with a PCO2 of 50, 60 all the time, their kidneys have time to compensate that and normalize the pH. But the acute hypercapnic, and most of your asthmatic patients should not have chronic hypercapnia. Their bicarb should still be normal, so you shouldn't be reassured by that.
What about, we do ABGs here, they're usually venous blood gases.
Yes.
Can you use that same?
Yes, you can. So your venous blood gas, your PCO2 will be slightly higher, but not enough for it not to be useful clinically. And actually, that's a point I make later in this talk is that when you have somebody on the vent, I would not be jamming their artery all the time. You don't have to do that. You can monitor their PCO2 with a venous blood gas. Normal on a venous blood gas, usually 40 to 45. Normal on an arterial is 35 to 40. So you can certainly use it as useful information. Yeah. Questions? Can you guys hear me back there? You're okay? Okay. So here's just a table from Medscape about when to intubate an asthmatic. So all the stuff we talked about. So persistent hypercapnia, they actually give you that cutoff of 55. If you have a PCO2 of greater than 45 in an asthmatic patient, I would intubate them. Increasing hypercapnia, so change going up by 5. Obviously refractory hypoxemia, hemodynamics instability, and certainly if they're comatose or apneic. It's time for them to chew some plastic. So what about BiPap? We'll talk more about what BiPap is, but just briefly, BiPap is a non-invasive way to ventilate somebody. BiPap is a ventilator. It's a ventilator. It's just a ventilator without an endotracheal tube. And I'll tell you, BiPap in asthmatics, the role is really unclear. And simply because those patients, if you're even considering BiPap, they're sick enough that they're scary and they end up intubated. We just don't have as much data on these patients. And so I would really caution you to not rely on BiPap very much in an asthmatic patient. It might be okay while you're awaiting their 20 milligram of albuterol neb to kick in, their steroids to kick in. You can try it for a while, but I would be very closely monitoring those patients. I would be checking on them all the time, and I would be ready to intubate them. If you call for BiPap in your asthmatic patient, I would also be making sure that there's preparation to intubate the patient, getting a ventilator ready, get your tube ready, get some backup from RT, etc. Intubating an asthmatic can make things worse. So again, you have to be very careful about intubating an asthmatic. Intubation alone, manipulating the upper airway, can induce worsening bronchospasm and laryngospasm. So patients can get worse as you're trying to intubate them. I would use a big endotracheal tube. You have to have a trade-off with your endotracheal tube about it needs to be big enough that you can ventilate them. Putting an endotracheal tube in someone's airway increases their airway resistance. It's hard to breathe through that straw. But everybody's nervous about being able to get the tube in, and it's easier to get a smaller tube in than it is a bigger tube. But as a pulmonologist, I would ask for 8.0 tube or bigger because you can't get a bronchoscope through a tube that's smaller than 7.0, and you'll increase the patient's airway resistance, which is already increased because they're bronchospasming, right? Their airways are tight, they're wheezing, you have trouble ventilating anyway, and you're going to make that harder the smaller an endotracheal tube that you put in. I would have your most experienced operator do this because, again, your asthmatic patient can run into serious trouble seriously fast, and so I would get back up, have your LMA ready, have your ER doc ready to help you, have if you have a glide scope, you guys just bought one, right? Yeah, I would have that ready too. Yeah. It's not like your daily one or something. Most asthmatic patients, you really need to do rapid sequence intubation. This is not a patient where you kind of give them a little bit of medicine, sedate them slowly. I would get it done and get it done quickly. The medicine that are often used, I typically use etomidate just because I have the most comfort with it, with a little bit of Versed. There's a lot of increasing evidence on using ketamine or propofol. Those medicines have some bronchodilation activity with them. I'll be honest with you, I've never used ketamine to induce somebody, but you can, and there's the dose. Propofol I've used, and I like it a lot. The big downside of propofol is that it causes hypotension, it causes a drop in your blood pressure. But most of your patients that are in the middle of an asthma crump, they're going to be hypertensive anyway, and so you don't care. It's fine to give them some propofol. I would actually recommend paralyzing them as well. You can intubate somebody without paralyzing them, and I do it all the time, but I wouldn't try that in an asthmatic patient because of the risk of the laryngospasm and the worsening bronchoconstriction, and because it reduces your chance of intubation success when they're not paralyzed, and it typically will take you longer. So I would go ahead and paralyze them and get it done, keeping in mind that when you paralyze them, then you're going to have to ventilate them if you can't get them intubated, so you have to be ready to bag them. You can use succinylcholine. It's what I use all the time. The only risk for succinylcholine is if the patient is hyperkalemic, and most of these patients will not be because you've already given them a ton of albuterol, and that pushes potassium into their cells, so typically they're hypokalemic if anything. But you can also use Nimbex, 10 milligrams of rocuronium, whatever you want. So ventilating a patient with asthma, again, is a challenge because what is happening in their airway, the pathology of this is they have bronchospasm, and so they are having trouble moving air through their constricted airways. They're having trouble moving the air in and out. So when you put that tube in and put them on the ventilator, you're going to have high airway resistance and you're going to have high peak pressures. The peak pressure is the highest pressure that it takes to put that breath, that tidal volume, into your patient. So when they have bronchoconstriction, you're trying to put that pressure through a smaller airway, a smaller tube, they're going to have high peak pressure. I would avoid using pressure support or pressure control ventilation. I would not just put in pressure control of 10, because if you put in 10 centimeters of pressure, you have no idea what tidal volume that patient's going to get, right? If their lungs are stiff and they're compressed and their airways are tight, they may get really crappy tidal volumes with that. So I would use assist control, I would use SIMV, a ventilator mode that allows you to give them an adequate tidal volume. The bronchoconstriction of asthma means that they're going to need a high inspiratory flow rate. You really have to put that breath in fast with a high amount of flow to get it through those constricted airways. And then they also need increased expiratory time. I don't know if you guys are familiar with the I to E ratio on a ventilator, but basically every breath gets a period of time. For example, if you have your patient getting 10 breaths a minute, that means every breath is going to get 6 seconds, right? 60 divided by 10 is 6 seconds per breath. And so part of that breath is going to be inspiration, and part of it is going to be expiration, right? They inflate the lungs and then they exhale. You really want to give your asthmatic patient plenty of exhalation time, because keep in mind, the constricted airways. So it's going to be hard for them to get that air out. They're going to need plenty of time to get the airflow through the constricted airways, okay? So your I to E ratio is how much of that breath, that 6 seconds, did they spend in inspiration, and how much do they spend in exhalation? And you set that being the ventilator, your respiratory therapist sets it. And I'll show you an example of what that means here. So this is like, for example, this would be your breath time here, okay? And so you have part of your inspiration, that's the flow in liters per minute, so you inflate the lungs during this amount of time, and then the patient starts to exhale. And as they're exhaling, you need to give them plenty of time to get back to zero flow, okay? Because if not, you're going to give the second breath while their lungs are not completely deflated, while they haven't had time to exhale. And so then you're going to end up air trapping. You're going to be stacking breaths on top of each other, and you'll get hyper and hyper and hyper inflated lungs. Your pressure will go up and up and up, and then eventually you can give the patient a pneumothorax where their lung just pops, and that's a disaster in this kind of patient, because then they have to have a chest tube emergently, because with that high pressure, they're going to get a tension pneumothorax within minutes. Does that make sense? Okay. So reasonable initial vent settings in your asthmatic patient, I would recommend assist control generally. I don't know what brand of ventilators you all use here, but most of them have either assist control or PRVC, which is a similar type of ventilator. And then your tidal volume, I would actually stick on the low side, like 6 to 8 milliliters per ideal body weight. So for your normal 70 kilo person, that's going to be a tidal volume between 4 and 550 milliliters. And I would set a respiratory rate actually a little bit on the low side with high inspiratory flow, so the patient can have that I to E ratio of at least 1 to 3, so you're giving them plenty of time to exhale. Your peak airway pressures are going to be high. You're blowing this tidal volume in through constricted airways. What you really want to watch is your plateau pressure. And I'll show you what that means. So when they give the breath in here, I'm going to stand up here. When you give the breath into the patient, you push that air in and you get this peak inspiratory pressure. If you have the patient hold the breath, and the ventilator can do a breath hold where they inflate the lung and then you do a breath hold, it'll give you what the plateau pressure is, and that's the back pressure from the lung, okay? Your ventilator is going to be alarming for peak inspiratory pressure, but keep in mind that that has to do with the constricted airways and not that the patient's getting too big of a tidal volume where their lungs are stiff. It's the peak inspiratory pressure that's the problem. Their plateau pressure may be fine, okay? And so ventilating the asthmatics, so these patients, like we talked about with the auto peeping, they are at high risk for hyperinflation. They have a lot of trouble with asynchrony, like they are trying to breathe faster than you want to let them breathe with the ventilator. They have a lot of intrinsic PEEP. These patients are really hard to ventilate. There's a high risk of pneumothorax with the increased pressures. I would keep in mind to remember that hypoxemia kills patients, not hypercapnia. We oftentimes will let these patients have a high PCO2. We will let them have a pH of 7.2, 7.15 in order to get them adequate oxygen and not overinflate their lungs and let them get stiff, okay? Hypercapnia doesn't kill people until it gets down to like 6.9 and they get so acidotic that they can have cardiac arrhythmias. So what you care about is you need to be able to oxygenate them and you need to be able to ventilate them some. But you can tolerate a PCO2 of 60 in your asthmatic patient as long as they're on the vent, as long as their pH is greater than 7. I don't know, 1, 1.5, or 7.2. Your goal is your peak airway pressure less than 50 and your plateau pressure less than 30, which they can measure on the ventilator. These patients are really tough, and I would tell you guys that this is not a patient that I would keep it with them. There's no shame in sending these patients downtown. That's exactly what I would do. Because of the risk of pneumothorax, the risk of asynchrony, these patients need an intensivist in-house 24 hours a day. And I can't do that with them. I imagine you can't do that here. I would not keep this patient in either one of our respective hospitals. Questions about that? Okay, I hope to God none of us ever see anything like that. Non-invasive positive pressure ventilation. So this is colloquially known as BiPap. BiPap is a a registered trade name of ResMed. It's a brand name, BiPap is. We often use it to mean non-invasive positive pressure ventilation because it's easier to say. But non-invasive positive pressure ventilation is a ventilator. So this is a way to ventilate your patient. You're just not putting a tube down their throat. This can be a full face mask. You can have a nasal mask, or you can even have nasal pillows. But for the most part, in the hospital, we use a full face mask just because that's the way to get the best seal and the best thing. The nasal mask and nasal pillows, that's for patients that are doing this at home. This is a tight-fitting mask that uses positive pressure to push the air in, and then also has expiratory pressure that helps inflate their lung and gives them PEEP and helps with their oxygen. So this helps both with high carbon dioxide and low oxygen. So the way you set BiPap is you want to set an inspiratory pressure and an expiratory pressure, an IPAP and an EPAP. And the way that works is the IPAP is the pressure that goes in when the patient inhales. So IPAP, EPAP, and as the patient breathes in, the machine gives them a high pressure to help inflate their lungs. And then as they start to exhale, it drops the pressure to allow the patient to ventilate and get rid of that breath, okay? It helps with their work of breathing, oxygen, and their ventilation. Some machines have a backup rate as well. And actually you can do typically BiPap with the same machine that you use for your ventilator, your same ventilator. It's just a different interface to the face mask. That's what we often do it with them. And that way if the patient fails, the same machine is still in the room and we just intubate them and hook them up to the ventilator that way. So think about it like a ventilator. So your IPAP minus your EPAP. So if your IPAP is 12 and your EPAP is 4, the difference between that is 8 centimeters of water pressure. That is the inflation pressure that you're using to get the patient to take a deep breath. That's basically pressure control ventilation, right? A BiPap is a ventilator. And your EPAP is essentially PEEP, positive end expiratory pressure. So BiPap helps with ventilation, and it also helps with oxygenation. And here's how. You guys probably remember some of this from medical school or your training. So PEEP helps distend your alveoli at the alveoli level, and it basically opens them up to increase your gas exchange surface area. So increasing the patient's PEEP will improve their oxygenation. PEEP doesn't do anything for their carbon dioxide, it ups their oxygen level, okay? And you can go up to 20 of PEEP, but after that, you're basically increasing the patient's risk for barotrauma without improving really the size of the alveoli. Here's just an example of the pressure with BiPap and with normal breathing. So normally, when we're having normal breathing, we breathe in, we breathe out. We breathe in, we breathe out. CPAP is a continuous positive airway pressure. That's what that means. It's one pressure. So basically, you're just raising the threshold at which the patient is doing that, okay? That will improve their PEEP. You're giving them oxygen doing that, but it doesn't really do anything to help them take a deeper breath or get rid of carbon dioxide. As opposed to BiPap, where you're making the patient, by using this extra pressure when they inhale, you're making them inflate their lungs more, take a deeper tidal volume, get rid of more carbon dioxide, okay? And then the EPAP is keeping their end expiratory pressure high, so again, those alveoli will open up and they'll get improved oxygen gas exchange, okay? Questions about all that? So, who should we be using BiPap in? COPD exacerbations are the classic patients who benefit from BiPap. So patients that have hypercapnic acidosis, so their carbon dioxide level is greater than 45, and their pH is 7.3, less than 7.3, okay? So patients that are in respiratory acidosis, hypercapnic respiratory failure, COPD exacerbation, you see it all the time. Hypercapnia, but a normal pH is chronic, and it may not need BiPap, okay? So I don't know how it is with you guys, but you get a call from the nurse saying there's a critical PCO2 of 60. Your next question should be, well, what's the pH? Because if their pH is 7.35, that's chronic, they don't need BiPap, okay? But if it's 7.2, then obviously they have not had a chance to normalize, that's not where they live, okay? So you'll see patients get slapped on BiPap a lot that may not actually need it because they have a normal pH, okay? Some COPD patients live with PCO2s of 50, 60, 70. cardiogenic pulmonary edema, BiPap helps those patients a lot. It helps with improve their oxygen gas exchange. It helps keep them from getting intubated. So if you have a patient that's in florid heart failure, cardiogenic pulmonary edema, that's really hypoxic on a non-rebreather, those patients really benefit from BiPap. You can keep them from being intubated. You can get them out of the hospital faster while you're waiting for your Lasix to work. Hypoxemic respiratory failure, obviously. So patients that are hypoxic, community-acquired pneumonia, patients that you can't seem to oxygenate very well using a nasal cannula or a venti mask or a non-rebreather, that expiratory pressure, that PEEP that BiPap gives them, will help them a lot. Post-extubation respiratory failure. So this is a new thing among pulmonary nerds. There's evidence that when you have patients that you've had to intubate for COPD exacerbation, when you extubate them, if you extubate them to BiPap, they sometimes will do better and they won't get re-intubated as much. You improve their chances of being liberated from the ventilator and staying off the vent. I've tried this a bunch. I have a lot of trouble getting patients to tolerate it. You know, you get rid of their sedation and you get them off the ventilator. They don't want something strapped to their face. They just can't do it. So in my clinical experience, I haven't been able to use this very well. And just my own pet peeve, BiPap often gets started for, quote, work of breathing, or the patient's short of breath, or they don't look right, or they look uncomfortable in the emergency department. And I have no problem with that, but I wish they would get an arterial blood gas when they order the BiPap. Because then the patient gets admitted to you up in the ICU, having been started on BiPap. You check a blood gas after they've been on it for an hour, and they're better, but you don't know what was going on to begin with. And so maybe they didn't need BiPap in the first place, so it's harder to know what's going on. So my recommendation to you guys would be, if you're going to order BiPap, get an ABG at the same time. Here are the contraindications to BiPap. So patients that can't protect their airway, can't cooperate with the machine, they probably can't do BiPap. It is not a comfortable, it is not a natural feeling to have that thing strapped on their face. Severely impaired consciousness, your patients with drug overdoses, narcotic overdoses, those patients probably can't do BiPap. Except patients that have CO2 narcosis, they can probably do it, okay? So your patient that's severely impaired because their PCO2 is 110, those patients you can give a trial on BiPap. If they've had facial surgery, if they're throwing up, if they have a recent esophageal surgery, I've never seen that one, but it's listed. Those kind of patients can't do it. And if you anticipate that they're going to have to be on BiPap for 3 days, you probably shouldn't do it. Okay. So how to initiate the BiPap? So I typically ask them to get an ABG at the same time. Initial settings are kind of like a ventilator. You set the IPAP, you set the EPAP. So the IPAP minus the EPAP, like we talked about, will be the pressure support that helps the patient take the tidal volume. And your EPAP is your PEEP. So I usually say BiPap 12/6, you know, and let's get a gas going in about an hour and let's see where we're at. Here's a protocol from up to date. I mean, here's all the steps. You want to have the patient sitting up, you want to have a good interface, apply the headgear, turn on the ventilator, check for air leaks, et cetera, et cetera. This is mostly your respiratory therapist doing. For us, we're basically setting the pressure and then giving it a shot. So how to monitor your patient on BiPap? I would repeat your arterial blood gas within 1 to 2 hours, okay? And it can be venous. Again, what you're looking for is a trend. What you're looking for is some improvement in whatever made you put the patient on BiPap in the first place. If the PaO2 is not where you want it to be, you can increase the PEEP, which is your EPAP, right? You can open those alveoli up more. If your PaCO2 is improved but not enough, you can increase your IPAP, which makes the patient take a bigger tidal volume, right? Or you can increase the rate and make them breathe more to blow off more carbon dioxide, okay? Ventilation versus oxygenation. And if they are getting worse after 1 to 2 hours, there's a very high percentage, greater than 90%, that they will fail BiPap and require intubation at some point. So if they are worsening after 2 hours, your best bet is probably to proceed with intubation and not wait till 2 o'clock in the morning when the patient's crumping and finally giving up. You know. How long can patients do BiPap? It is limited by the patient's tolerance. So the longer you have that thing strapped to their face, the more it hurts. They can get sores across the bridge of their nose, get erosions. But if they are getting better, what I typically do, and there is no data to support this, there's no guidelines about how to wean somebody off BiPap, we typically give them BiPap breaks, where they come off BiPap for several hours, the nurse lets them try to eat something, get out of bed, and then if they get to tire out or they start getting somnolent, the nurse has the option to put them back on BiPap, your nurse or your RT. I tell them, you have freedom to do that, just let me know when you do. And then typically, even if they look great, I have them put it back on while they're sleeping for a couple days, and then we try like a night without it and see if the patient can go home. I'll talk briefly about intubating patients for COPD because it's actually much, much easier and simpler than asthma. COPD exacerbations, we're all aware of this problem. There are 750,000 admissions for COPD exacerbation in this country every year. And I don't know how it is in Frankfurt, but in Lebanon, the smoking prevalence is 100%. And the COPD prevalence is probably 40%. There's some selection bias there, I know, but at least in my clinic experience, everybody smokes in Lebanon.
You're so sick.
Yeah, I know. It's not the Zionsville patients, it's the farmers in Thorntown and Antioch. And, yeah. No, it's not. So factors that increase your risk of severe COPD exacerbations. This is from the American Academy of Family Medicine review last year. Altered mental status, at least 3 exacerbations in the past 12 months. The patients that are really skinny, the pink puffers, marked increase in symptoms or change in your vital signs, severe baseline COPD, and the cutoff seems to be an FEV1 less than 50% of predicted or an FEV1 less than 0.7 liters is bad news for COPD exacerbations. Those patients are high risk for severe exacerbations requiring BiPap or requiring intubation. And patients that refuse to use their home oxygen, this is how they die.
Yeah.
So with, what's that, sorry? Yeah, they continue to smoke, yeah, so they don't burn their face off. So non-invasive positive pressure ventilation, so BiPap in patients with COPD and respiratory failure, it's been shown to reduce their length of stay, reduce their mortality. They're less likely to die if you use BiPap. It reduces infection, mostly ventilator-associated pneumonia, probably because you're keeping them off the vent. It reduces the number of patients that go to rehab stays or nursing homes. So if you can, I would recommend that you use BiPap in COPD patients. It's not like asthma. Asthma, you probably won't have a chance if they're that bad. But COPD, you usually have some time, and I would try BiPap in almost every patient unless they have a contraindication. So which ones need to be intubated then? So basically, the patient that's absolutely crumping in front of you, where the respiratory rate is 50, they're hypoxic, these are the patients that look like shit. You know, those patients probably are not going to do well with BiPap because it won't turn them around quick enough. Any patient that has one of those contraindications to BiPap, like we talked about, and failure of BiPap is the biggest reason. So 1 to 2 hours of non-improvement, that is enough time to know you're going to fail or you're not going to fail. They have this score where you can calculate this if you want to, but this is mostly common sense stuff. So if their Glasgow coma scale is less than 11, so those patients are really out of it, obtunded, their Apache score is high, their respiratory rate greater than 30, really acidotic, those patients have a 70% chance of failing BiPap. After 2 hours, if their pH is still less than 7.25, that's a 90% chance that they're going to eventually fail and require intubation, so you probably ought to proceed and save everybody a headache in the middle of the night. If you end up having to intubate your patient, families asking this all the time, patients that have COPD exacerbations that get intubated, their 3-month mortality risk is somewhere around 35 to 65%. They are very likely to die. It's basically a coin flip. Those patients are in bad shape. COPD ventilation. So very similar to asthma, but it's just easier because, again, with COPD, they don't have the same sort of bronchospastic airway resistance. They have more of a reduction in their elasticity of their lung. What I tell my patients is emphysema lungs are like a stretched out floppy pair of underwear. You know, they don't, when you inflate, when you relax, their lungs don't snap back. So it's not that they have high airway resistance. They technically do, but it's mostly because they don't have elasticity. Patients get it when I tell them that. You know, normally the lungs should snap back, but in their case they have floppy stretched out underwear lungs. So typically, just like asthma patients, you want to use assist control or pressure regulated volume control. The optimal tidal volume in COPD patients is really unknown. Most of your patients will have hyperinflated lungs. They will actually have bigger tidal volumes at baseline. So it's not like asthma where it has to be 6 to 8, maybe 8 to 10. We just don't know. The rate, we don't know that either. Probably 10 to 12. You monitor your blood gas and you adjust accordingly. PEEP of 5. And then again, same thing, right? In your office, these patients have prolonged expiratory phase, right? You see these pink puffers, these burnout old guys with emphysema and the great big barrel chest. The same thing happens on the ventilator. They need plenty of time to exhale, because if you don't give them that time, because their alveoli are floppy and not elastic, they're not going to get all that air out, and so they will breath stack and the pressure will go up. So you need to give them plenty of expiratory phase. And you watch their PCO2, but keep in mind your goal is a normal pH, not a normal PCO2. You know, that's my interns all the time when I was at Wishart. They would breathe the patient to a PCO2 of 40, but that patient didn't live at a PCO2 of 40, so now his pH is 7.5, 7.6, you know. So your goal is a normal pH, not a normal carbon dioxide. Okay? And the goal of the COPD ventilation is just to support the patient while your medications work. Support the patient while their steroids kick in, their meds kick in, their antibiotics. Patients need sedation, but not too much. Ideally, they have these scales, this RASS scale, -2. So you want light sedation, so you want to be able to wake them up and shake them and have them open their eyes, but not be fighting the ventilator. But sometimes that's a real challenge. Again, bigger tube is better because of the airway resistance, and you want to make sure the patient has enough time to exhale. And so, questions about that so far? I'm trying to get this so we have time for questions. So then the question becomes, when to wean your patient? When can he come off the ventilator? The recommendation is actually to begin spontaneous breathing trials the very next day. Even though the patient probably isn't ready yet, he's probably not all better, if you do spontaneous breathing trials every day, regardless if you think the patient can do it, that has been shown in clinical trials to improve length of stay on the ventilator, length of stay in the ICU, and hospital length of stay. So you ought to challenge them every day with a spontaneous breathing trial. And if you do it for 5 minutes and they're not doing very well, then you just switch them back, but you want to try. That's been shown to reduce all those things. We do a sedation vacation every morning during rounds. I mean, you can do it however you want, but what we do basically is we turn off their sedation every morning at 7 o'clock. I usually just call the nurse on my way in and tell them to turn off the sedation. I'm on my way in. And that way when I'm at the bedside, the sedation's off and we can see what the patient's doing. And when can you extubate them? So the spontaneous breathing trial is essentially a way to make the patient do the work of breathing. It's giving them a trial run to see what things would be like if you took the tube out. Can you breathe on your own? So we either do a T-piece, and what a T-piece is you hook it onto the endotracheal tube and it just blows oxygen by the endotracheal tube. It does not provide any support, no pressure support. It doesn't inflate their lungs. It basically is making them breathe on their own through that tube. Or you can give them a little bit of pressure support just to help them overcome the resistance of the tube on the ventilator. 30 minutes is all it takes. So the studies have shown if your patient can do a spontaneous breathing trial and do fine for 30 minutes, you don't have to make them do it all day to prove that they can come off the ventilator. After 30 minutes, you can extubate them. They're following commands, are they interacting with you? Whatever got them intubated is now better, like their pneumonia is better, whatever got them intubated, their heroin overdose in Lebanon, whatever got them intubated is now better. In patients with chronic hypercapnia, maybe you can extubate them to BiPap, but again, my clinical experience is patients really hate that. I can't seem to get them to do it. I'll kind of stop there. This is my cell phone number, and you are welcome to call it. If you've got a patient that you're having trouble with, I am happy to help you on the phone. It can be scary occasionally. Questions about any of that, all of that?
I do. Do you recommend, do you recommend peak flow home monitoring for your asthmatics?
I do. I especially recommend peak flow monitoring in my asthmatic patients that have frequent exacerbations and patients that have some, you can sort of get a sense from the patient in your office. If you have patients that don't seem to notice very well when they're doing poorly, the peak flow can help you a lot because it can help you identify patients that are doing bad sometimes before they even realize it. Certainly patients that have asthma exacerbations that land them in the hospital, I give every one of those patients a peak flow and we start charting it and we get a sense of what their best is, and then if they get peak flow gets less than 70% and 50% certainly, 70% they're calling my office, 50% they're coming to the ED. There are some recommendations from American Thoracic Society on you can decide how bad somebody's asthma exacerbation is in the ED by having them do a peak flow there, and that will help you predict if they're in trouble or not. In my experience, it's almost useless because you can tell by looking at the patient if they're in trouble. So the peak expiratory flow monitoring is best exactly as you described in your home patient that has frequent flare-ups that land them in the hospital. Yeah.
Would you comment on using inhaled corticosteroids in chronic asthma treatment? Let me just.
I'm in favor of it.
Well, there was a, that's what I thought. We had one of our hospital employees was concerned about Addison's and being tachyphylaxis and being addicted to inhaled corticosteroids and had many concerns and was actually promoting not using them at all. I think that, my understanding is the GOLD criteria is that's the number one medication for moderate, or even mild persistent asthmatic bronchitis.
You are exactly right. So inhaled corticosteroids are the mainstay controller therapy for persistent asthma. The side effects or the risks of those particular problems with the inhaled corticosteroids, although they exist, in my experience, they're very rare. I have not, even the risks of inhaled steroids like weight gain, like osteoporosis, like increased numbers of respiratory infections, I think are vanishingly rare. And I have not seen a patient that I've not seen a patient have rebound adrenal insufficiency after stopping their steroids. So whatever absorption of that they're getting, it doesn't seem to be enough to cause adrenal suppression. Again, in my experience, it is listed on the package insert. But no, inhaled corticosteroids are the mainstay of therapy because they prevent the long-term remodeling of airway disease. When patients have recurrent bronchoconstriction, that's actually bad because eventually they get airway remodeling and fixed obstruction. Your long-term asthmatic that's uncontrolled will turn into COPD. They will get scarring and fixed obstruction. So no, the GOLD criteria are, the first line therapy is inhaled corticosteroids. Now, in patients that can't tolerate it, and most of the patients that I found that couldn't tolerate it, it was because of thrush, even in low doses, and even with meticulous rinsing, or they had a lot of dysphonia, a lot of hoarseness, a lot of voice problems. You can use a long-acting airway dilator, a LABA, by itself, but keep in mind there is a black box warning about that in asthma in terms of the risk of sudden cardiac death and heart attack. And actually, although it's not FDA approved in this country, you can use inhaled tiotropium, Spiriva, as a controller medicine. There was a big article in the New England Journal last December of 13, that put patients that were on inhaled steroids, still having symptoms, put them on inhaled tiotropium, and they got better. So you do have other options, but the answer to your question is no, inhaled steroids are the mainstay of therapy, and your asthmatic that's using their bronchodilator several times a day, more than 2 days a week, should be on an inhaled steroid. Anything else? Questions?
How often do you order bronchodilator aerosols for your inpatient COPD?
For my
exacerbation?
inpatients?
Uh-huh.
100% of the time.
What's the frequency?
Oh, how often? I'm sorry.
What's a
So,
Q, how many
yeah.
hours?
So
Sorry.
albuterol, it's, we'll go up to Q4 on a schedule and Q2 PRN, depending on how the patient's doing.
Uh-huh.
Ipratropium, there's no evidence that using it any greater than every 6 hours is helpful. So you'll see patients get put on duo nebs every 4 hours, and that's probably wrong. They should not get ipratropium that much, simply because it doesn't help much more, and it's a very potent drying agent. They get very dry mouth, dry secretion. So I would put them on albuterol like Q6 with ipratropium, and then Q2 PRN, but the PRN is just albuterol, not additional Atrovent. Okay.
Do you nebulize anything unusual other than bronchodilators? I mean, not, do you put like, do you guys do like morphine or lidocaine or,
No, I've never done, I've done nebulized lidocaine in one patient that had intractable cough, and I was at my wit's end, and I was trying to nebulize lidocaine onto his cough receptors, and it was horrifyingly ineffective. It made him cough worse, but not routinely, no. The only other nebulized medicine that I typically use is there is a nebulized steroid that you can use, budesonide or Pulmicort nebulized.
Okay.
And I will use that in my asthmatics and my COPD patients, like my little old ladies that can't do an NDI. They just can't squeeze it right and they can't get the timing right. Or people with trachs that can't do an inhaler will do nebulized budesonide. But I almost never do it on inpatients because typically those inpatients are already getting IV steroids.
Yeah, no boatload of steroids anyway.
Right,
We're
exactly.
not gonna
Yeah,
add to
it's not
that.
going to help it anymore.
So when you send someone home and then you taper their oral steroids, do you have them start back on like their Advair or Symbicort when they're off the oral steroids, and you have them start, or do you do like a?
I typically have them do it at the same time, although Dr. Dominic's right, like you're giving somebody 60 of prednisone, the addition of Advair is not doing much in terms of the inhaled steroid benefit on their airways, but I want them to stay in the habit, and I don't want them to screw it up, and so like when they go home, I'm like, just start up your Advair, just do it, your prednisone will be done in 9 days or 15 days or whatever, however you guys like to do it. So I usually will have them do both. And actually, I'll put them back on their Advair when they're off the vent, when they're in the hospital. I just want them to stick with it. And I usually have samples in my office. I just bring one over so the hospital doesn't have to waste one.
The other one I forgot about was she reminded me, racemic epi, do you ever do that for upper airway stuff?
Yes.
Okay.
Yes. So
Or-
yeah, we'll do racemic epi nebulized in patients that have stridor. You can do it in asthma patients. I've never done it, but it supposedly can be helpful in your patient that has severe obstruction. And we also will sometimes do what's called heliox, which is a mixture of oxygen and helium. That's it's a little slipperier. It has less airway resistance. So your patient has stridor that's getting hypoxic. You can put them on heliox. Patients that have epiglottitis or some sort of upper airway obstruction that you're waiting for your decadron or your antibiotics to kick in. You know, I haven't had to do that with them, but yes, you can, and I have in training.
What about for bronchiolitis for RSV? Do you still order routine like Q4 aerosol albuterol, or do you do a bronchodilator trial, or what do you do, or do you deal with those kids?
Those are mostly children, so I was telling them we now have this new respiratory pathogen panel where we are able to detect RSV quickly, and when I'm testing my COPD patients, I have seen a lot of them that have come back as positive RSV. But it's not the same disease in adults that it is in kids, it seems like to me. I mean, they're basically just having a COPD flare-up.
Yeah.
So I'll be honest with you, I have not seen or taken care of much true bronchiolitis RSV. So I don't know. Okay, thanks for your time, appreciate it.
Thank you so much for coming.
Yeah.
Thank you.
Yeah, please.
So, yeah, we have a lot of this before you and